In terms of the primary outcomes, in the experimental group, most of their wounds healed. Remember, they talk about what constitutes healed toward the beginning of the paper. Healed constitutes complete closure defined as skin functional and structural integrity regeneration, right? So most of the experimental arm wounds healed. Welcome to the Clinical Appraisal Podcast. My name is Ian Lane, and on this show we discuss the science and theory of nursing. I'm a critical care nurse and PhD student in nursing science focused on measurement and methodology. Importantly, nothing I say constitutes nursing advice. This is education only. And if you want to get in touch with me, please email me at clinicalappraisal@gmail.com. If you want to donate to the show, links are in the description. And otherwise, like, comment, subscribe, and share the show if you enjoyed this episode. Recently, I undertook a kind of informal scoping review of the scientific literature across 3 databases, Scopus, PubMed, and CINAHL, to find out how many randomized trials are there in the discipline of nursing. And it turns out there are approximately 6,000 papers that are specifically labeled or purported to be randomized trials in nursing. The vast majority of them are either some form of pilot or feasibility study or a quasi-randomized or quasi-experimental study. That's not that surprising when you think about the fact that nursing is a young-ish discipline, at least from a scientific lens, and not a lot of nurses appreciate the randomized methodology, which they associate to be implicit with the biomedical model of care. It's not, or at least it needn't be. But suffice to say, the other reason it's not that surprising is because there are so few nurse scientists. There are few people that are looking at nursing interventions. And then so few nursing interventions have actually been examined that one typically begins with a pilot study. And then the fact that pilot studies have to be replicated in larger efficacy and or effectiveness studies, typically, it's hard to imagine us having enough resources to have had that happen over again. As in, has an intervention study been replicated after the pilot to show efficacy, to demonstrate efficacy of the intervention? Most often not, although I'm not exactly sure yet because I've not finished this scoping review. I am undertaking it as we speak. That said, one of the things that I'd like to do is go through the non-pilot studies, non-feasibility studies, traditionally randomized clinical trials, specifically with nursing practices in mind. But I specifically am interested in finding out what justification do we have as a discipline for purporting that we have evidence to base our practices on, and then where precisely do we lack evidence for critical patient care needs at the level of bedside nursing, and it's bound to be extraordinary. So what I'd like to do is begin with a paper I found recently by Dr. Alessandro Sili from Italy and colleagues. They did a phenomenal job with this paper. The paper was originally published in the journal Advances in Skin and Wound Care, I believe. This was a republication in 2023 in March of this year in the journal Nursing Management. The paper is called Specialized Nurse-Led Care of Chronic Wounds During Hospitalization and After Discharge, a Randomized Controlled Trial. And I'd like to point out a couple things. And what I intend to do here, and hopefully if people like it, I'll continue to do these, is do another one of my study reviews where I go through the intricacies of the paper and discuss a little bit about my feelings about what I find compelling, where there might be some issues with, which in this paper were very few, and discuss a little bit about what I think the findings mean, if anything, in a generalizable sense, and what implications it may or may not have for our practice going forward. So this is the first time I've seen anything like this done publicly ever. And I'm proud to be able to do it. I've seen other professions do it, and I think it's time that we have something like this in nursing. And if nothing else, my objective is to inspire other nurses and nurse scientists to be able to do similar studies, to be able to say, hey, you know what? This is actually an area I practice in. Maybe you practice in wound care nursing. And if that's the case, maybe you find some of these issues compelling enough and you're seeing the same types of holes in your practice and you want to go identify possible solutions to these holes. So let's get started with this. First, I want to point out that all of the authors on this paper are nurses. They all have an RN license, and they all have this bedrock of nursing practice underlying whatever it is that they're doing next. I know a couple of these individuals from the acknowledgement section are involved in new doctoral programs in, for example, biomedical and translational sciences. I think Monaco is interested in biomedicine to some degree, and Mosca, I apologize if I said that incorrectly, is interested in translational sciences. I might have those flipped, but the point is they all have this bedrock foundation of nursing knowledge at the core of what they will learn from here. So let's start. What I want to do is I will read a little bit from the paper. You can see I've highlighted different things here. We'll talk about why as I go through, but essentially I'll read the parts of the paper that from a consumer point of view, from a scientific consumerism perspective, I find important. I think, and it's possible to read this in innumerable different ways and come up with different things that you think are potentially extraordinarily important that perhaps I missed. And again, if you're watching and you see something I missed, A, put it in the comments, and B, I mean, good for you. I think that's great, because there are numerous ways to read key papers like this. I'm going to start with some of the introduction. A wound is damage to or disruption of the normal anatomic structure and function of skin and subcutaneous tissue. Chronic wounds are hard to heal, lasting longer than 8 to 10 weeks, and are characterized by a slow repair process, a greater probability of infection, and the presence of necrotic tissue. That is the first quote from the introduction. For those of you that are not familiar, scientific papers like this, typically like clinical trials, are organized in a very specific way. It typically goes introduction and then methods, as you can see here. And then we have sample size, randomization, statistical analysis. This is all part of the methods. And then results, as you can see here. And then the results are purely findings from the study. You are not supposed to write anything about your interpretation of your findings in the results section. They didn't. I'm just saying that for your edification. And then you have the discussion section where you can write your conclusions. The authors typically discuss the implications of their findings and more. And then there sometimes is like a summary paragraph, a conclusion of a slightly different sort that kind of just synthesizes their discussion section into a single paragraph or two, and then acknowledgments at the end. Often, as you can see here, there's a limitations section toward the bottom of the paper. That, I think, is always an important thing to have, particularly in light of the fact that this is a clinical trial. So let's go back up to the introduction, and I apologize for for going off on a tangent there a little bit, but just to familiarize some of you who are not as readily familiar with the scientific literature, how this is organized. And the thought process actually matters, I might add, because oftentimes it's hard to follow if it's not in this format, and then authors can sometimes get away with things that maybe they shouldn't. And again, I want to point out, these authors did everything virtually flawlessly. It was almost so good that I thought, like, am I being duped? Is this actually a real study? And it is. I mean, it's real. So let's continue. The global prevalence of chronic wounds has been estimated as 2.21 per 1,000 people. That is 0.221% of the entire population. That doesn't sound like a very large number, but overall, across the globe, that's an extraordinarily large number of people in total who deal with chronic wounds. I highlighted chronic wounds extra there because it's important to recognize we're not talking about acute wounds, we're talking about chronic wounds that persist up to sometimes 75 days straight. Quote, to face this challenge, healthcare organizations implemented targeted interventions and drafted or updated clinical care protocols to prevent and treat chronic wounds. Among such strategies, creating specialized clinical care pathways such as nursing clinics and training healthcare personnel dedicated to wound care, such as specialized wound care nurses, have proven to be the most effective. And of course, here they are just summarizing research that's relevant to the problem that others have conducted in the past. They do make a comment here. I just want to touch on this. You'll see it's in gray. This is because, to me, it doesn't make as much sense. And in this context, it's in light of United States nursing practice. So this might just be a difference in location, in geography, and the fact that the regulations for specialist nurses in Italy might be quite different than they are here in the US. But it says specialized nurses, such as advanced practice nurses, clinical nurse specialists, or nurse practitioners, all of whom can be referred to as wound care nurses. In the US, wound care nurses are often licensed registered nurses at the baccalaureate level. They don't have to be at the master's level. They can, but they needn't be nurse practitioners or advanced practice nurses. And in the US, and this may be very different in other countries. In fact, there's, I think it's Morocco, a friend of mine who's a nurse scientist who I met at the Eastern Nursing Research Society conference this past year, is, I believe she's from Morocco, and every RN in Morocco is also, I apologize if I'm getting the location incorrect, but I'm pretty sure it's Morocco. They're all required to also be midwives there as well, which is interesting. So sometimes there's variance in geographic location in terms of nursing practice. So it could be that all advanced practice nurses in Italy or at least near this location in Rome are considered wound care nurses. In the US, not only is that not the case, I think most nurse practitioners would consider themselves not wound care nurses, or that they don't have some special expertise in wounds, which I think is a problem because nursing is so close to the kind of patient care required to have, and maybe this is one of the takeaways from this paper, is that because nursing is care provided at the bedside, you are getting, forgive the sort of unintended pun here, but closer to the problem to be able to care more sufficiently for wounds. But we'll kind of set that aside for a moment. Continuing on with the introduction here. Quote, previous studies tested the introduction of wound care nurses during hospitalization and found that these professionals improved care outcomes such as wound healing and infection rates and had a positive influence on length of stay. Significant results were also found in hospitalized patients in terms of wound healing and reduction in healing times when pressure injuries were proactively cared for by wound care nurse specialists compared with those, ignore my cat, with those treated according to standard practice. In the context of this study, I don't actually understand what standard practice means yet. I'm not sure what the standard model of care they're referring to is. And at this point in our reading of the paper, we can't be sure. Now, of course, I've read this whole paper, but I still, after having read the whole paper, don't exactly know what the standard model is. They've not described the model here. Now, it's strange to me because they've described everything else in this paper so well that I'm surprised they didn't include like a line or two. And maybe for them, it's just so obvious over there what the difference is. And again, for me in the States, I don't know if they assumed that I would read this over in the States, or that we would read this in the States. But we are. And I'm not clear on what the differences are between the nursing model and the standard model, other than the fact that nurses are not involved in the standard model. Except that's not true, because as you read on, you find there are nurses involved. They're just maybe only involved in the in-hospitalization phase of the project. It's hard to know. So one of my only grievances with the study is that because it's a randomized trial, in which that there's two randomly allocated groups generated under study, one of which is a control group receiving standard care, the fact that I don't understand what that means, I think is problematic. But it's really one of the only problematic things that I've come to find in this paper. Okay, continuing on, quote, most wound care studies have enrolled patients who are in specific clinical settings, such as hospitalization, home care, or outpatient clinics, and their evaluated outcomes relate to that setting in particular and to the period when a specialist nurse was in charge of wound care. Although the role of the wound care nurse, care continuity, and patient-centeredness are essential elements for the management of chronic wounds, outcomes associated with them are analyzed in relation to each clinical setting independently and fail to consider how long the wound has existed and any previous treatment provided. This often happens as a result of care transitions. I'm going to unquote for a second and also point out that many of the studies that look at this, and I'm not a wound expert or an expert on the wound literature by any stretch of the imagination, are likely to be pre-post tests and not longitudinal. Not only was this a randomized clinical trial of wound care specialty nursing practice outcomes, it was also a longitudinal study that looked across a significant length of time. Quote, and this is in red, pinkish, because this is a key thing that you have to take away from this paper. Quote, the authors hypothesized that introducing a nurse-led wound care approach to promote the care of patients with chronic wounds both during hospitalization and in the period after discharge would make wound management more effective, given the positive influence of wound care nurses on hospitalized patients' wound management, the importance of transitional care, and the negative impact of chronic wounds on patients' lives. The aim of this study was to evaluate the effectiveness of specialist nurse-led care of patients with chronic wounds provided both during hospitalization and post-discharge on wound healing rates and readmission rates. There's a lot in there, unquote. There's clearly a lot involved in that, but what it tells you is that the aim of the project, importantly, is to examine things like wound healing rates, hospital readmissions for wound-related complications, and essentially these core outcomes of chronic wound care by examining these two groups, one of which is receiving this specialty nurse-led care during these care transitions and post-discharge from hospitalization. We'll continue on. So now we're in the methods section. This is the section that describes what the study was about. And I apologize for those of you who are yourselves scientists or researchers or nurse scientists or people who are otherwise familiar with the scientific literature, but just periodically humor me and allow me to give some context to folks who are listening who are students, who may not know, or who just are interested and may not have this understanding already. So this was an unblinded, single-center, two-arm or parallel randomized controlled trial. And the objective was to compare standard care with the effectiveness of specialist nurse-led wound care of patients with chronic wounds. To report this study, the authors adhered to the consort checklist. I love this. This is a very important key element for me as a methodologist. Lots of people don't use the consort checklist, and it's impossible otherwise for me as an intelligent consumer of their research to find out what exactly happened to people in their study from eligibility screening throughout the end of the project. In discussing the setting, quote, the study was conducted from January 2017 to December 2020 in a university hospital in Italy, where the management protocol used for acute and chronic wounds was inspired by the time care, that is, tissue infection or inflammation, maceration or dryness, the progression of the epithelial margin care, which refers to time of treatment and wound healing. That's a lot if you're just listening to the podcast. But the point is, there is this time care model for the treatment of and healing of chronic wounds. The time care model was developed to standardize wound care approaches. Yada, yada. Okay. Who was included in the study? So in terms of participants, patients who met the following inclusion criteria were enrolled in the study. They were adults with chronic vascular, diabetic, or pressure wounds, or dehiscence and complications of surgical wounds, or burns. So already you can tell that one of the limitations of the study, and maybe it's not readily apparent to you that it's a limitation, but you should think about this as you read papers like this. They just lumped a number of different subtypes of chronic wounds under the same umbrella and called it wounds. And of course, these authors know this, and they point it out to their credit a couple of times in this paper. But for your edification as a reader, as an informed, intelligent consumer of the nursing literature, when you think about method sections like this, and you read who was involved in the study, what was the primary outcome of the study, and what subtypes of disease processes or what have you were included, you need to consider the fact that vascular, diabetic, pressure wounds, dehiscences, and surgical wound complications and burns are all different subtypes of wounds. Now, they're all wounds. They all fit under that massive umbrella heading of wounds, and that's fair enough. But what the authors write later, and what you would come to recognize as you read through the paper, is that it could be possible. And if you think about it for 30 seconds, you can imagine a situation in which different types of nursing care might influence different subtypes of wounds differently. And as I said, Dr. Sili and others fully recognize this. I apologize, Alessandro, if I'm saying your name incorrectly. I'm really trying. Continuing on, patients were excluded if they were younger than 18 years of age or had cognitive deficits or were not adherent to the therapeutic plan. They also go on to say this includes failure to comply with medication intervals or missing multiple visits. This is a good example of the differences between an efficacy and an effectiveness study. In the real world, patients drop out. They attrite from therapy. They drop out from study protocols all the time. It's just not the case that, if you think about it in terms of like a diet study, for example, you cannot expect compliance uniformly across the different patient populations included. And you'd be hard pressed to imagine a world in which every single person who was enrolled in that study fully adhered to the dietary regimen at all. It's just not possible. So part of what you do in analyzing a study like this is you include everybody in the analysis, whether they dropped out or not. And you analyze the study data it's called an intention to treat analysis, where everybody is included, all of their data, all their results, including those who dropped out, including those who had some negative outcome or adverse event. And the reason is because in the real world, that is what encapsulates the true effectiveness of the study protocol. So what this is doing, the fact that they were excluding people for failure to comply or excluding people for missing multiple visits means, two things. One, it means they're using a per protocol analysis, which is a type of analysis where you only analyze the people who complied with your project, which increases bias, but it specifically increases a type of bias where it's an interpretive bias. It's the overgeneralizing of the result. That bias is increased in this, but these authors are not actually engaging in that type of interpretive bias. So I would say what they're really doing, and the other thing that it tells us, is that they're really conducting an efficacy study here. How efficacious is this project under kind of perfect circumstances where everybody analyzed is compliant? The reason it's not an effectiveness study is because effectiveness implies real world. And the real world nature of any intervention is that people often drop out or are not adherent. So what were their primary outcomes? Anytime you're reading a study design section of a research paper, you want to think to yourself, what was the primary outcome of the paper? What are the secondary outcomes, if there are any? And is the paper powered sufficiently to detect statistically true effects if they are there to be found? The primary outcome of this study was wound repair and healing. And this microphone is quite nice. It just picked up the start of my husband's shower. So the primary outcome is wound repair and healing. And there are some secondary outcomes, which we can discuss. Oh, that's why I was confused. If you're watching, there's some journals like to do this thing where they put a quote taken out of context and slap it somewhere in big bold text in the middle of the paper. I was confused because these columns are read straight down, left to right. The secondary outcomes are listed above this weird break in the page here. In any case, let me read this piece again to make sure that it's coherent for those who are just listening. Quote, the primary outcome of this study was wound repair / healing, or complete closure, defined as skin functional and structural integrity regeneration, unquote. Quote, secondary outcomes were rate of readmission within a time window of 30 days after discharge, and the number of treatment days, weeks, and accesses to the clinic after discharge. Unquote. Continuing on methodologically, following enrollment, the researchers randomly assigned patients to one of two study groups. The first thought you should have, and the first thought I had when I read this, as I get to this point talking about the randomization process, is what is the randomization process? How were they randomized? In what way did they assign people or randomly allocate people to these two different groups? To their credit, again, this is described. It's just described on a different page below. So one thing to think about is if you're a student writing papers is the flow of when you're reading a paper, what do you typically expect to be in that section or the next section of that paper? There are a couple other important pieces in this section, kind of as a side tangents. During hospitalization, patients in the experimental group were treated on the unit by wound care nurses from the nursing clinic. After discharge, they continued specialized treatment in the wound care nursing clinic. This is important because it tells you exactly what the experimental group is getting in terms of their exposure. The exposure is treatment by specialist wound care nurses in the hospital and outside the hospital post-discharge. But then in the control group, patients were cared for according to routine practice. They were cared for by, quote, unit nurses during hospitalization, and upon discharge were referred to nurses and physicians at specialist clinics, such as surgical wound dehiscent specialist in the outpatient surgery clinic and vascular ulcer specialist in the outpatient vascular clinic. Here is where I get confused. To me, I can't tell the difference between their standard care where they're referred to nurses and physicians at specialist clinics. There are nurses at those specialist clinics, and presumably they are wound-trained nurses. Like, one of the things about this project is, it was a fantastic study. It was designed well, it was executed brilliantly, and the results are so striking. One of the things, this is just my prickly spider senses as a methodologist reading this as an intelligent consumer of the scientific literature, you so infrequently see effect sizes that are so large or statistical results that are so big and magnificent as the ones I will be showing you toward the end of this paper in their findings section, that when you see things like that, you start to wonder, like, is this real? Now, it could be that their experimental arm was just so incredible and important that the results are so starkly different and they are real effects. Now, I'm not saying I don't believe them, because statistically things seem to be valid and reliable. Fair enough. But what I am seeing is there are specialist nurse-led care post-discharge, outside the hospital, after hospitalization care. Okay. But then there are also specialist nurses post-discharge outside the hospital at clinics that the control group were referred to. So I guess where I'm confused is the only difference between the groups and the big difference that's accounting for all these magnificent effect size differences between arms, is it all due to the fact that one is nurse-led versus one is physician-led? Is it the fact that nurses are leading it versus simply participating in it that's different? I just can't tell. And if I happen to have a conversation with Alessandro, I'd love for this person to be able to help enlighten me and illuminate this for me, because it's hard for me to know exactly what this means, what takeaway I should have in terms of what standard care really means and what the differences are between the two arms. The reason I'm harping on around about that is because a clinical trial with a parallel arm randomization, where there's group allocation to these two different arms, implies that you're getting two different interventions. And if the interventions overlap and seem similar, which is fine, in a sense it's fine as long as the thing that makes them differentiable is the thing you're testing. And I mean, to me, part of what it's lacking some face validity to me. Like, on its face, it's hard for me to see what that magnificent difference is that the statistical analyses are showing. So going back to the paper, we have sample size. You always want to ask yourself, and I always ask myself, how big was the sample? What sample size did they have? Was it justified? Did they justify their alpha? Did they justify their sample size with a statistical power analysis, etc.? Those are the same thing. Quote, sample size was determined based on the primary outcome of wound healing. Cool. At least 178 patients, with 89 patients per group, and an extra 10 patients for each group to allow for a possible 10% dropout was included in the study. Therefore, the researchers sought at least 198 participants to reach a statistical significance of a p-value of less than 0.01 with a power of 90%. I did double check these, and so two things. Firstly, they are correct. This power analysis works out just fine. And I can verify that this power is real if they have 198 participants. They had 1,298 participants. They're well more than fully powered to be able to detect real effects in this paper. So it's almost comical to read this power analysis. Like, most people will conduct a power analysis and they'll say, we need 78 participants to have a statistical power of 0.84. That's a little ridiculous, but you get the point, right? And what they'll do is they'll recruit, 76, and then 2 will drop out, and they'll have 74, and their statistical power will be 0.796. And they'll be like, we had virtually 80% statistical power, therefore, yada, yada. This is like the opposite. And it's not, I was going to say the opposite problem. It's not a problem at all. This is, we need at least 198 participants to have a statistical power of 90%, which is pretty damn good. And then, but we actually got 1,298 total. So we're way past that. Like, it's just almost funny how that worked out. In terms of randomization, I asked, what was the process of randomization? How did they actually randomly allocate these people to these two different arms of the study? They used block randomization, a sequence of 4, 5, and 8 generated on a website called randomization.com. Totally valid. That's fine. This was well done to prevent the investigators predicting sequences of randomization, which is the reason you do blocked randomization. And the blocked randomization is usually, this is the only way I can see, like, there might be some wiggle room for investigator bias, but at this point, I don't know why. I don't have reason to, but I trust them for some reason. When you do blocked randomization, it's hard, especially if a separate analyst has designed your SAS code or your R code or whatever statistical code software you're using to code this randomization scheme. If they do this independently and don't share it with the investigators, they have no way of predicting exactly who will be in what group until they're in that group. So the block randomization schedule is a fantastic idea. Quote, because of the nature of the intervention, blinding of group allocation to participants, healthcare providers, or research personnel was not possible. End quote. You can imagine you get randomly allocated to the nurse-led group and you find out, oh, the person leading my team is a nurse. You can't really be blinded to that. Continuing on, importantly, under the statistical analysis section, I promise I won't spend a ton of time here. Quote, to provide an estimate of the true efficacy of the nurse-led wound care intervention, patients' data were analyzed according to the per-protocol analysis. The per-protocol analysis is what I was talking about before when I highlighted the fact that they have a certain amount of dropout or attrition from the study, and they're leaving those individuals' data out of the final analysis to get a purer understanding of how efficacious this protocol of nurse-led wound care actually is. Continuing on, quote, the independent sample t-test and chi-square tests were used to identify possible sex and age heterogeneity in patient groups, respectively, and to check the difference in the mean days of treatment and clinic visits. This data exists in Table 3, and I don't understand exactly what they mean by days of treatment here. They don't specify this exactly. Again, Dr. Sili, if you're listening, I cannot, as an intelligent consumer of this literature, understand what you mean precisely by days of treatment. I can make assumptions and speculate, but because it's not explicitly written in a way that makes sense to me in the paper, it's hard for me to understand what that outcome actually represents. If it's total days under treatment with this nurse-led care, if it's total days of treatment while they had an open wound that hadn't closed or healed yet, or something else, if that helps to kind of clarify my misunderstanding. Continuing on, a one-way analysis of variance and a Tukey post hoc multiple comparisons test were conducted to verify the difference in the mean days of treatment and the mean number of times patients accessed the services. In addition, chi-square relative risk and confidence intervals regarding wound healing and other outcomes were calculated between the patients cared for at the wound care nursing clinic and those cared for at other services. Other services here means standard care, whatever that is. Again, I can't really tell. Authors conducted Kaplan-Meier analyses to compare wound healing time distribution between the two groups. Results were considered statistically significant at p-value less than 0.05. The sample size was so large in this project that this is irrelevant. It doesn't actually matter. But the power calculation determined that the alpha was set at 0.01, not 0.05. And they, in like 3 paragraphs before this, explicated that their 90% power essentially required an alpha of 0.01. So if your statistical significance for your power analysis is set at 0.01, and then you, in your method section, claim that something significant is 0.05, you are no longer in accord with your power calculation. Now, again, this is for a different project because this project had like an ungodly number more patients in it than what their power analysis would have presumed. However, for a smaller trial, that would actually matter. So I'm pointing that out for students who might be interested in that, and for the savvy who are paying attention to some of those little pieces in the data. They have a comment about their ethical considerations, which all clinical trials that are responsibly done typically copy and paste. It's the same kind of wording about the Helsinki Declaration and adhering to the kind of core ethical standards of clinical trials. So this project was registered under researchregistry.com. It seems like the vast majority, maybe 40-ish% of researchregistry.com registrations are essentially done in Italy. They're trials that are registered in Italy. I didn't actually know about this this website, rather. In the United States, we use the National Clinical Trial Registration, NCT registry, something to that effect. I've had to register a clinical trial at the medical school, a couple clinical trials at the medical school. And I imagine it's a similar process, looking at their registration site, which if a clinical trial, essentially, if they state that they are using a trial registry, you should look. If you look at the trial registry and you find out that what was reported in the paper that was published is different, and where it's different matters, than their clinical trial registration, there might be some bias that's sneaked into the paper. Importantly for this, their registration maps on perfectly to their paper. The only things that I struggled with in looking at their registration was the fact that their control group and intervention group are described verbatim, the way that they are in the paper. It's just copied and pasted. And clearly it's copied and pasted from the registration to the paper. That's fine. Except I still cannot tell, based on that description, what exactly the differences are. And again, I wonder, is it just the fact that this is nurse-led versus physician-led care? I can't really tell. And then at the end of their registration, it asks whether they intend to share individual participant level data, and they say no data sharing planned. I think, and I should clarify for those that are not aware, these are usually de-identified participant level data. We're not talking about like patient identifiers here. At least that's my own understanding, and that's the way we do it in the United States. Data sharing individual participant level data is really just sharing the raw data of your project. This is another place. I'm not insinuating that this is true for this research team. Please understand this. But what I tend to assume as a methodologist when I look at studies like this is if they have a registration and they have no plans to data share individual participant level raw data, what I think to myself is these analyses look pretty good. If I had their data and I had the opportunity to reanalyze their data, would my results look just as good? And I don't know the answer to that, and I'll never know the answer to that unless this piece changes and they do start sharing some data. So that was the introduction and the methods. Now we're on to the results section. Quote, this is, unquote for a second here, this is the study sample. They typically, in clinical trials like this, in reporting, we talk about who was involved in the study. You know, in the method section, you talk about the sample you're trying to recruit and who's eligible and why, or why not, in inclusion and exclusion criteria. For something like this, what we're trying to determine is who fits criteria for inclusion into the study. But the results section is, these are the individuals we actually recruited. So it's sort of like proposed numbers and characteristics versus actual numbers and characteristics. Quote, the study enrolled 1,570 patients. Recall, they needed a total of 198 participants to have a power of 90% to detect meaningful effects. So, they enrolled 1,570 patients. 794 were randomized to the experimental group and 776 to the control group. Dropout rates in the experimental arm were 11%, so a total of 87 people. And A total of 185 people dropped out of the control group, which is 23.8% of the total patients. Remember, these people were excluded from the study sample for the final analysis for the sake of their per protocol analysis design. And the idea, again, if the authors were trying to make claims about effectiveness per se, I would be highly skeptical of this type of analysis. And intention to treat analysis is much less biased from this interpretive bias perspective. However, the investigators make it a very plain, and they do a good job of it, that what they're trying to show is the efficacy of a nurse-led wound care intervention. I'll continue. Most of these patients were lost to follow-up and did not adhere to the treatment plan. Again, this would happen in real life. In an intention to treat analysis, you'd keep them all in. They were excluded from analyses according to the per protocol approach. We talked about that already. The problem with having done a per protocol for this, and I understand that what they're doing is trying to demonstrate efficacy of their protocol, which is important. The issue is that now they're forced to do a follow-up randomized trial, and randomized trials take time and they're expensive. And in this follow-up study, they'll have to do an intention to treat analysis, including everyone's data in the final analysis, to look at effectiveness in the real world, which they might have enough data to look at everybody, and they could do an intention to treat analysis regardless to see. Perhaps that's not outside the realm of possibility. This is a statistical result, which is why it's in purple highlight. Quote, the patients were predominantly women. The sample size there was 731, or 56.3% of the final sample, with a mean age of 65.5, with a standard deviation of 16.6 years. This means that the individuals included were majority female, but I mean, that's pretty close to 50%. I mean, clearly it's closer to 60. Like, it's still a predominance in terms of the fact that is that the majority were women. But it's not as if there was a preponderance, a vast majority of females, that you wouldn't be able to say anything about men. And the fact that the study was so well powered, I'm not super worried about that. It's not like a huge problem. Actually, I don't think it's a huge problem at all. The one thing that is a big consideration about this line is that the mean age of the population is 65.5 years of age, which means that that 67% of the population under study in this were between the ages of like 48 and 82. So when you think about that, in the context of extrapolating results from a clinical trial, you need to understand that these results will only apply to individuals of an older age bracket, above the age of 40, most likely. Patients in the different groups were homogeneous regarding wound type, number of comorbidities, sex, and age, which they show, at least for sex and age, statistically with p-values of 0.22 for sex and 0.08 for age, respectively, which are non-significant, which is good. It's what you want at baseline. You want at the beginning of the study for the two groups to be as identical and equally distributed as possible. That's the point of randomization. The point of randomization is to eliminate investigator bias as much as possible, ideally totally eliminate it, and to equally distribute the unknown unknowns between the intervention arm and the control arm. I hesitate there for a second because there are different types of designs, like stepped wedge designs and crossover designs, where both sets of, or all sets of people, or the entire population under study are at some time in the study seeing the experimental or intervention arm, or intervention protocol, rather. In terms of the primary outcomes, in the experimental group, most of their wounds healed. Remember, they talk about what constitutes healed toward the beginning of the paper. healed constitutes complete closure defined as skin functional and structural integrity regeneration, right? So most of the experimental arm wounds healed. In the control group, however, non-healing wounds and adverse clinical outcomes such as death were more common. That's in red because that's the primary outcome, right? That's the most important component of this results section for this intervention. But all this purple, these are just other statistical outcomes that are important for this paper. Quote, the risk ratio analysis regarding wound healing found that nurse-led wound care management quadrupled the probability of healing compared with standard care. The risk ratio was 4, hence the quadrupled. That's the first time in a scientific paper I have ever read quadrupled instead of 4 times or fourfold or something like that. I quite like quadrupled. Importantly here, the risk ratio of 4 means that, and I calculated these myself a little bit earlier, the absolute risk reduction is 0.6. And that means that the number needed to treat, so the number of people you would need to put in this intervention for one person to benefit is 1.8. Now, that's an irrational number. You can't have 1.8 persons, but you can allocate 2 people to this nurse-led intervention, and one of them will get this quadrupled benefit in wound healing. Now, first of all, that's amazing, if true. And I'm still skeptical because this is the first study I've ever seen of it, so it would have to be replicated. Keep that in mind. Couch this in the perspective that this is the only study of its kind that I've seen, and this is not my area, so maybe there are more. But what I can say is that this would still have to be replicated in another follow-up study. Nonetheless, a number needed to treat of 2 is enormous. The number needed to treat of the COVID-19 vaccines were, gosh, I forget exactly, but they were in the hundreds. Now, with billions of people vaccinated, that's actually hardly an issue. There are numbers needed to treat for certain medications that are in the thousands. The fact that this is a 2, virtually, almost a 2, is unbelievable. So, continuing on with the results here, quote, nurse-led wound care management reduced the probability of non-healing wounds by 1/3. This is actually an error. So you'll see their risk ratio, their RR, is 0.34. A relative risk reduction of 0.34 is actually a 2/3 reduction in the probability of non-healing wounds. That's actually a 0.66 reduction, or 66%. So it's actually even more than they make the claim. I think that that's just a typo. I think that they meant to say 2/3. Regardless, that's a huge effect. Continuing, and reduced hospital readmission rates by 80%. And you can see here, it's actually 82%, but they rounded to 80%. Fair enough. Even the confidence intervals are tight. So this is what I mean. This study, as you look at every individual piece of this study, you start to see, like, it's excellent, but B, it's so excellent at times you're like, is this real? So there are moments where I wonder to myself, like, especially in light of we don't want to share our individual level data, the raw data, that makes me wonder if I were going to reanalyze this, if I would get the same results. But operating on good faith, and I trust the authors here, or I'm forced to trust the authors here. Continuing, statistically significant between group differences were found for the mean days and weeks of treatment, the number of outpatient visits, wound healing, non-healing wounds, deaths, and readmissions. This is in Table 3. We'll look at Table 3 in a moment. Continuing, the log rank test for the Kaplan-Meier analyses showed that wound healing time, quantified in weeks, for the 2 patient groups was significantly different, with a chi-square of 267 and a p-value of less than 0.001. That is a highly statistically significant result with a profound chi-square result. And as you look at the Kaplan-Meier curves in a moment, you'll be able to see exactly how big that looks, which is why depicting it in diagrams is so important. But we'll check that out in a second. So those are the main results. Reductions in wound healing time, reductions in readmissions, reductions in adverse events and deaths. It's important. This is an important contribution to the literature if true. And there's enough statistical power here, clearly, that these results are at least, I mean, they're profoundly more likely to be showing meaningful, true effects. So moving on to the last piece, the discussion here. Quote, most patients enrolled in this study were women and averaged approximately 65 years of age, which is in line with previous literature reporting higher prevalence of women with chronic wounds. I actually didn't know that women had a higher prevalence of chronic wounds. I would have assumed that men who have a higher rate of diabetes and diabetic complications, from what I know back from nursing school, so this could be off a little bit, I would have assumed that they would have had a higher rate. But this kind of speaks back to the point that they're looking at different subtypes of wounds and different classifications of wound types. So they're looking at diabetic foot ulcers. They're looking at pressure injury wounds. They're looking at burns. They're looking at neoplastic wounds. So they're looking at a whole umbrella, a giant category with a ton of subclassifications of wounds in it. And the prevalence for different types of wounds is going to be different, sex stratified among the different subgroups, I would assume. But then if you average them, it looks like maybe more females than males have chronic wounds, which is interesting. I actually didn't know that. Quote, specialist nurse care also reduced the treatment time and the number of visits to the wound care nursing clinic. This is very interesting also in red because this is a key component. Now, the entire time I've been reading this study with you and thinking through this, I've been curious and confused about what exactly comprises the difference between study arms. What's different about the intervention arm compared to the control arm, other than the fact that it's nurse-led? Let me reread this line again. Specialist nurse care also reduces the treatment time and number of visits to the wound care nursing clinic. First of all, it's a wound care nursing clinic, so it's nurse-led, that's implied. But then maybe one of the core outcomes is that the requirement of greater, let me figure out what's the best way to phrase this. The number of times people needed to see their wound care specialist implies something about how well they're doing and how well their wounds are healing. The less you needed to see the specialist wound care nurse, the better you were doing. So if they needed to see them less in the nurse-led care environment, that's an interesting and important outcome because clearly things are healing faster and better in that group. Quote, patients with chronic wounds cared for by the wound care nurses completed their treatment at a mean of 10 weeks, whereas treatment among patients in the control group took a mean of 12 weeks to complete. That speaks back to this point about the time frame problem as an outcome. Interesting, 2 full weeks earlier of healing in the nurse-led care group in terms of these wounds. What you're seeing on the screen here, if you're watching the YouTube version of this, is a consort flow diagram. The consort is essentially, as I said at the beginning of this episode, what happened to all of the study participants from the time that they were deemed eligible from your screening form to the end of the study and the final analysis. You can see here that there were 1,590 people enrolled in the study that were assessed for eligibility. 5 people did not meet inclusion criteria. That's fascinating. I think this just elucidates or illuminates some of the differences between like some of the work that I've done in the psychiatry realm and in the kind of pain science world, where you might have inclusion criteria that are pretty specific that lots of people don't meet. But like wounds, like bad chronic wounds, if they have a bad chronic wound, they're more likely to be fitting the inclusion criteria. But to have 5 people out of 1,590 not fit the inclusion criteria is very interesting to me. Also, super interesting, 15 people declined to participate. 15 people out of 1,590 people is just 0.94% of screened individuals who did not want to participate. That's another one of these examples of like borderline unbelievable to me. I'm not saying I don't believe them. And I think now I've said that like 5 times and it really sounds like I don't believe them, but I swear I'm not saying that. I do think that this is conceivably true. But it's amazing. As somebody who has conducted clinical trials and registered clinical trials myself and done this process, 15 people electing not to participate out of 1,590 it's amazing. But I don't want to get stuck for those of you listening who are not trialists and who don't care about that nerdy stuff. So that means they randomized 1,570. They allocated 794 to the intervention arm and 776 to the control arm. They're pretty evenly split. Remember, this was from that 4, 5, 8 blocked randomization sequence. From there, for the follow-up, they had 73 people lost to follow-up in the intervention arm, and then 14 discontinued the intervention. They dropped out for one reason or another. They don't talk about why they dropped out in here exactly, which is another nitpicky thing I'd like to have had them discuss a little bit more. It's like, what happened to these people that were lost to follow-up or discontinued the intervention? Did they discontinue because they died? I mean, that seems important. We don't actually know why they discontinued. And then amongst the control group, 143 were lost to follow-up, which you can see is more than in the experimental arm, the intervention arm. Whether it's statistically more, I'm unclear on. And then 42 of them discontinued the intervention. Those numbers might say something about patient satisfaction of non-nurse-led versus nurse-led specialty wound care, but they didn't measure that, and that's not a study outcome, so we actually can't say that based on these data, but it's interesting, and it's how kind of my mind is thinking about this as I read this paper. And then finally, for the final analysis, 87 were excluded from the intervention arm, and 185 were excluded from the control arm. So that left 707 people to analyze in the final analysis in the experimental arm, the intervention arm, and 591 in the control arm. These are large numbers. 1,298 people, I think it was. Yes, 1,298 in the end is a huge sample size for a study that's powered for 198 people. It's fine. That's fine. It works out great. But it's still a per protocol analysis that only allows one to speak of the results as efficacy related and not about, you can't say anything about effectiveness of this in the real world. I wanted to say importantly that all of the numbers in a consort diagram have to add up to the total assessed for eligibility at the beginning. So this consort diagram is like a tree of what happened to these people. And as you look at this tree, the beginning had 1,590. They excluded people, people dropped out, blah, blah, blah. In the end, 1,298 1,590 minus 1,298, you get the total number of people that either dropped out or were excluded. So all of these numbers do, in fact, add up, which is exactly what they're supposed to do. What I want to do is take a look before we close a little bit more at some of the diagrams. And I think they're powerful and they will show some important elements of this project visually for those of you who are watching the YouTube version of this podcast. Continuing on, remember, this is the discussion section. So now in the results section, you are presenting the findings as they occur. Some of my professors have stated it this way: just the facts, ma'am, just the numbers, please, So the results section are just the findings only. No interpretation of the findings. Don't say anything about what you think it means. And they didn't. They did a fabulous job writing up the findings. Just the statistical analysis results, right? The discussion, you can talk about what you think this means in light of some of the things you talked about in the introduction section, and discuss in kind of a summarizing, synthesizing way how to slot this into what we know about the topic already. Quote, in this study, wound existence quantified in days was significantly lower than in previous studies, and wounds healed in a shorter time when patient's care was managed by the specialist nurse during the entire clinical pathway. Although wound healing is a long process and physiologic aging delays tissue repair, this study found better results in the experimental group than in the control group in terms of wound healing, length of treatment, and rates of readmission, despite a mean age of approximately 65 years in both groups. So this is a little bit on the irrelevant side, but because the control and the intervention groups both had statistically non-significant differences in age, you actually can't make comments about differences in healing by age. So it's not a criticism of the authors. What they're trying to do is say, I think, previous literature associates rates of wound healing with age of the participants. But then they go on to say something in this about their protocol and the rates of healing of wounds in this sample. But the differences in age were not significant at baseline in this sample. So they actually can't, there's an inference here that's implied that they can't make. And I'm not suggesting that they are trying to make it, but I know that some readers will try to make it. So that aside, key feature here of the paper, quote, results from this study indicate the benefits of implementing a nurse-led wound care, starting at the hospital and continuing in the wound care nursing clinic. This piece, I feel like, is the thing that should be highlighted more throughout this paper, that it was not just in the hospital, because in the hospital there was nursing care of presumably the same type of this wound care regardless. But it was post-discharge from the hospital in the community that this specialty nurse-led wound care, I think, made the biggest difference. I don't actually know, but I'm guessing as I read this that's the important part. Quote, the care continuity provided by the specialist nurse is predictive of healing of chronic wounds, which is achieved in a shorter time and with less recourse to outpatient services than when standard practice is applied. That is exactly what I was thinking. The nurse-led care of chronic wounds also predicts a lower rate of hospital readmission and unhealed wounds. These favorable outcomes could be related to effective nurse-led wound care management based on planned care continuity and effective nurse-patient communication, leading to reduced treatment time in the experimental group. I think it's important to recognize that statement, this piece about these favorable outcomes are related to XYZ, continuity of care, care transitions, nurse-patient communication. These are hypotheses that are not tested or testable with these data. Or testable with these data is maybe a little stretched too far on my end, but it's not tested in this data set, in this published study. And so this piece that they're pointing out here is an implication, an interpretation, but not a finding. This is not something that we can say based on these data. It's just a hypothesis, which you can do in a discussion section, that's fine. But this is a hypothesis about this data set that these authors are trying to purport as being plausible explanations for some of these findings. Investigators also noted that, a statistically significant between-group difference in adverse clinical outcomes such as death. Hugely important. As we look at table 2, that shows us here on the screen, table 2, clinical outcomes, N of 1,298. That's our final sample included in all final analyses. You can see those who healed their wounds, who had non-healing or non-healed wounds at the end of the study, and then adverse clinical outcomes. Interestingly, that's where they included death. Maybe death from the wound deserves its own subcategory. I'm not really sure, but adverse clinical outcomes is actually an umbrella category with all sorts of different possible negative outcomes that might have occurred between the two groups. You can see that these results are highly statistically significant on the right here. Between group differerences, you can see were conducted with chi-square tests. This is because these groups were not normally distributed, and so they used chi-square instead of t-tests, for example. And the p-values were less than 0.001. These are highly statistically significant, and you'll recall at the beginning, I highlighted the fact that they are employing Tukey's post hoc multiple comparisons test to make certain that these are actually statistically significantly different. And they are. And so these are actually different groups, different categories. Quote, non-healed wounds or a slow tissue repair process could be related to patient deaths. I appreciate how careful the authors are in describing what they think might be related. Overall, I'm very impressed with the way that they describe the results of their project. I think a lot of authors, a lot of researchers broadly, are a little bit too liberal in their over-application of, or their over-extrapolation of their results, rather. Future studies should implement the nurse-led wound care model and evaluate patient survival as a primary outcome. I agree. While taking into consideration clinical variables of wounds, comorbidities, and other individual factors to better understand this connection and confirm these preliminary results. I also think that they should make the claim that future work needs to test the subcomponents of this nurse-led care. Nurse-led care is a broad category. What features of the nurse-led care are leading to these positive outcomes that were so staggeringly huge in this study, which I'll show you in the Kaplan-Meier curve in a second. It's profound. But these profound changes are stemming from some features of these two different approaches. The fact that something is nurse-led isn't, like, as a nurse, that doesn't tell me how to do things differently for a patient. And as a nurse-led organization, because this isn't about individual nurses doing anything, it's an organizational model. But in that organizational model, there have to be things that another organization can do other than just assign a nurse leader to lead the team to then garner all these results. Point being, like, what are the special ingredients that are leading to these high levels of important key differences between groups for nurse-led and non-nurse-led specialty wound care? We can't tell based on this study alone, but it would be really good fodder for a future structural equation model. And as a specialist in structural equation modeling, maybe the team will contact me for future work. When we look at the treatment days, weeks, and number of clinic visits, in table 3, you can see treatment days, treatment weeks, and number of clinic visits on the left as the parameter they're trying to evaluate. And this is one of the areas that I don't fully understand. I don't understand what it represents. Again, I mentioned this earlier, but is this like total number of treatment days or weeks? Or is it weeks during treatment where the wound was in a certain stage of the healing process? It wasn't described sufficiently for me to understand exactly what that means. I know you're going to see the Kaplan-Meier curve in a second here if you're watching the YouTube version of this, but kindly kind of keep that to the side for a second here, but I'm going to read the limitation section because I think they did a good job, with one exception, which is the first line. Quote, "The monocentric nature of the study may influence the generalization of results." I have no idea what the monocentric nature means. Dr. Sili, with all due respect, I feel like somebody wrote that, whether I don't know how it came to be, but like if the centric element of that word is supposed to be reflective of the center, that it was a single center, single site project, just say that. It was a single center study. So the single center nature of the study, the single site nature, the fact that it was a single site influences the generalization of results. When you say influences, what you really mean is it reduces the generalization of results. We can't generalize to other sites based on one site. You need multi-site trials to be able to generalize organizational interventions to other places, which is one of the big limitations here, which they point out to their credit. But just the phraseology there, I think, needs to be tweaked. That's a stylistic thing, not a big deal. Quote, "Moreover, the study evaluates only some of the care and organizational outcomes of wound care nurses taking care of patients with wounds, with chronic wounds, clinical wound variables, patients' comorbidities, and the causes of readmission rates were not analyzed." I like that they mention this, especially the causes of readmission, because we're not really getting that information in this project. We're really only left to speculate. And the other thing I wanted to make sure I mentioned is that this future work piece we're talking about here, like future research should focus on X. I think not only should we figure out what are the unique contributing factors of the nurse-led model that lead to enhanced and improved results from this care, we also need to figure out what are the downsides of the standard model. What are the things we're trying to not do anymore on the other side? And while there might be some significant overlap there might be some discriminant validity to tease out to be able to point out these things are really helpful and these things we should avoid when we're implementing organizational interventions around nurse-led wound care. Quote, "Further, researchers chose to use a per protocol analysis. Participants in the study were enrolled in the final sample only if they strictly adhered to the treatment plan with no interruptions." I very much appreciate that they highlighted this. I know that I've talked about this ad nauseum so far, but the fact that they highlighted it themselves means that they are well aware that this is an efficacy study and not an effectiveness study. Quote, "And the heterogeneity of the wounds treated is also a limitation." I think that they talked a little bit about the preponderance of women in this study. I don't think it's it's not like a vast majority. I don't think it's a huge deal. I think it's a bigger problem that it's an organizational intervention that was only done at one site, and therefore, despite having enrolled 1,590 people and capturing data for the per protocol analysis on 1,298 people, which kind of makes me wonder if they could have done a multi-site trial and why they didn't elect to do that for this generalization problem, given that they were able to bring so many people into this trial. I'm less worried about the 57% of women in the study than the close to 40% of men in the study. But what I think is important here is this heterogeneity of wounds treated. There are all different types of subclassifications of chronic wounds, as we talked about. Maybe it could be the case that certain types of nurse-led care have better or worse outcomes in certain subclassifications of chronic wounds. I, of course, have no idea because I know like 3 things about wounds and I'm a noob. So that's, regardless, it could be that there are some special, unique ways in which certain types of wounds are better cared for by nurse-led organizational interventions like this than others. That said, I would be, again, less worried about that. and a little bit skeptical of that as a criticism of this and a limitation of the study, because even though it is technically a limitation, if you think about it, nurse-led and non-nurse-led wound care clinics all see a variety of wounds in their patient populations. So this is sort of I guess I should avoid using the word standard when their control group is called the standard model, but that's the kind of typical scenario. Finally, they say, quote, "This randomized control trial investigated the effectiveness." They didn't. They investigated the efficacy. That's a point of contention I have. Of specialized nurse-led care of patients with chronic wounds, provided both during hospitalization and after discharge on wound healing and readmission rates. Patients in the experimental group showed improved outcomes in terms of wound healing and reduced hospitalization within 30 days, compared with patients cared for according to standard practice. Key element here. To confirm these results, multi-center studies with samples stratified by wound type and characteristics are warranted. Future research should use an intention to treat analysis. Good for them. I could clap if it wouldn't be super annoying. And evaluate clinical variables of chronic wounds and patients' comorbidities, such as diabetes or hypertension. Again, another critical component here, quote, "Further, it would be useful to include patients' individual perspectives to highlight qualitative aspects influenced by the implementation of the nurse-led wound care model." This is where something like a cognitive interviewing strategy could be useful to come up with a kind of working model that might measure the clinical functions associated with specialty nurse-led care in the wound care space. This study provides healthcare organizations with evidence supporting the need to reconsider the care pathways of patients with chronic wounds. Again, this is an organization-focused intervention, not an individual-focused intervention. As an individual licensed nurse myself with questions about, like, what do I do specifically? What are the ingredients in my clinical practice that would benefit people with wounds? That actually says nothing for me. But organizations that participate in the wound care kind of space, this is an intervention that gives them some crucial information. It just doesn't tell them precisely what the ingredients of that are. Patients benefit from a holistic and patient-centered approach, sure, guaranteed by the expertise of a wound care specialist nurse who takes care of the patient by performing assessments, planning, coordinating, and delivering care, and reevaluating and monitoring the interventions to be implemented. Here's where they start to talk a little bit about what the nurse-led care looks like at the very end of the paper. And then they say they have a similar role as case managers. Case managers, at least in the United States, typically are nurses. So maybe they're not wound care nurses, but they're trained as nurses. They usually were nurses for a long time first. I'm going to set that aside. The pointing out of performing assessments, planning, coordinating, delivering care, reevaluating, monitoring the interventions to be implemented. These are things that they're purporting to be part of the nurse-led care. But if you pay attention to those things, with the exception maybe of coordinating and delivering care, which are not exclusive to, but they tend to more typically be reflective of nursing practice than of medical practice, those are all things that physicians do too. So I still don't know what exactly the difference is between the standard care model and this nurse-led care model. If these are the things that differentiate it, I think they're in for a problem when they go to look at the special ingredients, as I called it earlier, in something like a structural model. In a replication study, I'm not sure what would come out of that. I think, so before I go back to this, I'd like to end on this really positive note for the study team. But before I do, I just want to talk a little bit about what I see as the big takeaways from this study. So 2 takeaways for me. The first takeaway is that I have never seen, with one exception, which I talked about on the podcast last year, there was an economics-based study of nurse practitioners' full practice authority rights done by I feel badly because I'm going to forget her name, but a woman from Pennsylvania who I have a significant respect for as a nurse scientist, who conducted a fantastic study. But the methods section in that paper was done by an econometrician who was familiar with statistical modeling. And so it wasn't all that surprising to me that it was really well done quantitatively. But for this paper, every single one of the authors on this paper were nurses. And yet it was brilliantly designed and excellently executed. And it's one of the best nursing RCTs I've ever seen so far. And finally, what I'll read is my conclusion, my personal conclusion, which I think overlaps pretty well with the authors, based on this study's findings. Quote, results show me that for some individuals in this location of Italy who are in older adulthood, over the age of 40 years old, a specialty nurse-led wound care clinic with nurses with over a decade of experience in wound care nursing can reduce hospital readmission rates for wound-related problems, reduce complications and adverse events associated with their chronic wounds, and significantly increase wound healing time by 2 full weeks compared to a standard model. Unquote. And then finally, if we look at figure 2, we can see the Kaplan-Meier distribution curve between groups for wound healing time. They looked at this by weeks. I assume that the 0 to 1 scale on the left, they say cumulative survival, but calling this a survival curve is one way of thinking about a Kaplan-Meier distribution. I think the better way of thinking about it is a time to event distribution. Typically, time to event for the case of a Kaplan-Meier for aging, for cancer research, is usually mortality, but it doesn't have to be. In lots of cancer research, they use not secondary, but like primary outcomes that are not mortality per se, and they still utilize a Kaplan-Meier distribution curve to show the efficacy of something, say some new chemotherapeutic agent or something. In this case, you can see the time to wound healing, and you see the green sort of squiggly line here is the experimental group, and the blue squiggly line is the control group over the weeks that are listed at the bottom. I'm going to make this a little bit bigger. Not that you need it to be bigger. You can see the break in these curves early on, and it's a dramatic break. Now, for context, I'm going to show you one last thing, and that is this screenshot that I have here on the screen of a separate Kaplan-Meier curve. This is showing growth and survival probabilities of something totally irrelevant, has nothing to do with nursing, nothing to do with this paper. I'm only showing you to demonstrate what Kaplan-Meier curves typically look like. This is a pretty typical Kaplan-Meier curve. When you look at these curves, the degree to which these lines separate essentially shows you the magnitude of the effect of how different they are and how statistically significant that effect is. These lines are pretty close together. It makes it difficult sometimes to tell exactly which groups are actually different. The null hypothesis in statistical, at least frequentist statistical modeling, tells us that these groups are not different until proven otherwise. Almost like the opposite of it's a little bit like innocent until proven guilty in the Western legal model, right? It's until you demonstrate that there is some difference that's real and meaningful, these groups are the same. So what they're trying to show is that these lines move apart. Now, it could be that at this point of the curve, somewhere around here, if you can see my cursor, the blue squiggly line here, 1989 to 1999. Remember, this graph is irrelevant for the paper we're looking at. These lines come apart. Maybe that piece of the pie is statistically significant, but at the end of the study, maybe they're statistically similar enough that there's no difference between groups, and therefore you would not find a statistically significant result with a Kaplan-Meier curve like this. Now, look at this Kaplan-Meier curve. The differences between groups are staggering. Looking at charts like this, it always depends on like what level of analysis you zoom in or out on the chart to determine, just how magnificent these differences seem. But no matter which way you slice the data, this is an enormous sample, and this is a staggeringly large difference between groups almost immediately, which again, I can't help but wonder, like, what exactly happened at the beginning in the nurse-led group specifically that made these two groups so drastically different that you were able to see these profound breaks between groups in a Kaplan-Meier curve so early on in weeks. All in all, this is a phenomenal study, and I'm extremely proud of the researchers in Italy who conducted this work, and I think we need to see more studies like this in nursing science.